And good morning. Well, good afternoon now. It's afternoon. And now I lost track of what I was going to say, of course. So good afternoon, everyone. Thank you for being with us today in this community chats extra to close the diabetes month. We know diabetes, we've been saying it all month long, that a lot of people out there have diabetes. A lot of people have it and they don't know that they have it. And then those who have diabetes can be very confused about all these different medications that are out there for diabetes, different kinds of insulins, tons of treatments, and everybody might have something different, and we don't really know what is what sometimes. So in order to clarify a little bit of that confusion, we have Joanne Rinker here with us today. She's from Mankind, and she is really going to help us today to understand a little bit of what's happening with diabetes medications out there. Just a reminder to use the icons at the bottom of your screen, the Q&A or the chat. Ask all your questions there. I'll be happy to read your questions to Joanne, and that way, you know, we can have a more interactive experience. So don't hesitate to ask all your questions. Welcome, Joanne. Thank you so much for being here today.
Thank you, Sandra. I know Sandra wanted me to do just a quick introduction first. So I just wanted to let everyone know I'm a registered dietitian. I'm a diabetes care and education specialist, just like Sandra. And I have been in this diabetes space for about 22 years, working with people with diabetes, working with diabetes care and education specialists and providers. And I want this to be an opportunity for me to share information, but also for you to ask me questions. We're going to talk today about insulin, and I really want to make sure that any questions you have about insulin, that we answer those today. Any questions you have about conversations you've had with your provider or family members, you know, I'm happy to cover those. So let's go ahead and get started. And just let me know if you want me to stop. So some of the things I want you to know that we're going to cover today. We're going to talk a little bit about the timeline of insulin therapy. It's actually, there's a lot of innovations that have happened over the last 100 years that we've had insulin. We'll talk a little bit about that. We'll talk about how insulin actually works in the body. We'll talk about who actually requires insulin. So people with diabetes, we'll talk about kind of which people really need insulin the most. We'll talk about how insulin can be taken. There is actually a variety of ways. It's not a one size fits all. We'll talk about the different types and characteristics of insulin, the physiologic, so what's actually happening in the body, and then what our target range should be for our blood sugar, and any side effects of insulin therapy for people with diabetes. Which the most common is a low blood sugar, but we can talk a little bit about that, and then also how to prevent and treat low blood sugars. And then overall life with diabetes. So let's just jump right in. So as I mentioned, we've had insulin available to us for about the last 100 years. So we were able to isolate it back in 1922. There were animal insulin preparations in 1923, but there was human insulin in 1977. And then in 1990, there was rapid insulin analogs were created. That rapid insulin is what's used especially for mealtime to cover the amount of food that is eaten at a meal. And then in 2000, basal insulin analogs were created. And that basal insulin is actually insulin that is released very slowly all throughout the day, which is very similar to what's happening in the body of someone who doesn't have diabetes. So how does insulin work? The way I like to think about insulin is that insulin is actually this key that unlocks the cell and takes glucose from the bloodstream and puts it into the cell. When it's in the cell, that glucose can then work as fuel. So if you wanted to go for a walk or if you wanted to go to a yoga class or go swimming, the glucose in your cells is what's going to be burned as fuel. One of the problems and one of the reasons why people need insulin is because if they don't have enough, then all of that glucose is just staying in the bloodstream. And so imagine that when we have all that glucose, which is sugar, in the bloodstream, our blood would then flow like syrup instead of like water. And so when you think about the risks that that has on the body, it means that that's what makes that blood so hard to flow to places like the tips of your fingers or the tips of your toes. So if you've ever had someone before say, I have this numbness in my fingers or my toes, or I can't really feel my feet, people that have diabetes, it could often be because that blood sugar has stayed so high for so long. And they haven't had that ability for the insulin to unlock the cell and get that glucose out of the bloodstream and into the cell. So that's what's most important. That's the role and that's the goal of that insulin. And so what I want you to remember, because oftentimes people will say to me, oh, Joanne, the doctor is telling me that I have to take insulin. And, for me, I say, well, if you need it, then you should take it, because your quality of life is going to improve when you're getting this glucose out of the bloodstream and into the cells. You'll have more energy, you'll feel better, you'll decrease those risks of complications from having all of that glucose in the blood instead of in the cell. And this is why that insulin can be so powerful as a medication for people with diabetes. So let's talk about who needs it. So keep in mind that there are multiple types of diabetes. There's pre-diabetes, and those are people that actually have some lab results that are in range, that if they don't take some action to prevent diabetes, and this is preventing type 2 diabetes, that they may eventually develop into a person with diabetes. So that pre-diabetes means that there is some indication that there is this excess sugar in the bloodstream, but it's not high enough for a diagnosis of type 2 diabetes. So I'm going to go out of order. I'm going to talk about type 2 diabetes first. These people, basically, there's a few things that could be happening in the person with type 2 diabetes. One is that their cells actually don't respond to insulin. So it's actually called insulin resistance. They have this resistance to that insulin unlocking the cell and letting that sugar in and out of the bloodstream. That's one thing. So there's three things. So it's insulin resistance. The other is that they may be deficient in some insulin. And so their pancreas might be creating some insulin, but not enough to unlock all the cells that are in the body and let that sugar out of the bloodstream and into the cells. So that's the second thing. The third thing is that their liver actually might be producing too much sugar, even when the person is eating. So it's this insulin resistance, it's making not enough insulin, and maybe it's making the liver making too much glucose, and that's in the blood. So these are the things that are happening with type 2 diabetes. So not everybody with type 2 diabetes needs insulin immediately, but what I do want you to remember about type 2 is that it is progressive, which means over time, what happens is the pancreas kind of gets pooped out. Insulin is actually made in the pancreas. And I say that, after someone's had type 2 diabetes for 20, 30, 40 years, their pancreas is just pooped out. So it's not making enough insulin. Or that insulin resistance. So those are some of the times when people with type 2 diabetes need insulin to supplement any other medications or lifestyle changes. Now, the other type of diabetes is type 1 diabetes. Now, people with type 1 diabetes make little or no insulin. for the first 6 months that they're diagnosed, they may actually be able to make a little bit, but after about that 6 to 12-month period, these people are making no insulin. So they need both that basal insulin, that insulin that's released all day throughout the day, but then they also need that rapid acting insulin, or that insulin that's released each time they choose to have a meal or a snack or something that's going to raise their blood sugar. So remember, for the people with type 1 diabetes, these people need insulin to survive. Most of those people are on these intensive insulin regimens. So this is a combination of that basal insulin that they might take every morning when they wake up or every night when they go to bed. Every body is different, and so it's very individualized what their regimen might look like. But then additionally, these people would also be taking insulin at each meal. Sandra, I'm going to pause because it looks like we have a question or something in the chat section. Oh, okay. So I see the question. The question is asking, is it safe to use SGLT2 inhibitors in insulin-dependent type 1 diabetes who have fluid overload, systolic heart failure with reduced left ventricle ejection fractions in a synergistic combination with angiotensin receptor, so like an ACE or an ARB or something like that? Okay, so this is very, very specific, and asking, which also reduces hemoglobin A1C levels. I'm not sure if this is a question or if this person was just sharing this specific research. So I'm going to pause here and we'll come back to that one. Okay. So how can insulin be taken? So what I want you to remember is that just like care is individualized, so should the mode of insulin delivery. This really should be based on the comfort of that person. What is it, or how is it that is going to be best for them to take insulin if insulin is being prescribed? So you see all the options here. One is that they could use an insulin syringe and vial. And so you see the man holding the vial and the syringe, and you would just bring up the insulin into that syringe and then you would inject. That's one way. Another is an insulin pen. And so you see that with the man that's pinching his skin and putting the pen in his abdomen. And so the difference with that is that that requires you to just do some turning. And so you would like turn and it would say 6 units, 7 units, however many units you're going to take with that meal. And you don't have to actually draw it from a syringe and a vial. So that pen is an option. Another is an insulin pump, and that's what you see kind of in the bottom left, where you see that there's an insertion typically in the abdomen or the arm, wherever a person decides that they would like to put that insertion site. And then they are actually getting insulin. They use an app, or they can use a small device where they're putting the amount of carbohydrates or their blood sugar. And then based on those numbers, the pump will actually say, okay, based on this and some settings that you have put in already with your prescriber, then those numbers will indicate how much insulin a person should take. So they don't need to inject, they would just need to change that insertion site every 3 days. That's an option. And then the last is inhaled insulin. And so inhaled insulin is an ultra rapid acting insulin that is taken in an inhaler. There's 3 different size cartridges for that dose, and it is typically used for each meal. And so for breakfast, lunch, and dinner, you inhale at the start of your meal. So those are the 4 different options for how insulin can be taken. So mealtime or bolus, that's really they mean the same thing, but you may hear bolus when you're talking to your provider. What it means is that this is the insulin that you take when you're eating food. So either at a meal time, at a snack time, those kind of things. And so ultra rapid acting insulin is that inhaled insulin. That's taken right before the first bite of food. Rapid acting, which can be in a pen or a vial and syringe or a pump, that is usually taken right before the meal. Short acting insulin also can be in any of those pump, pen, vial, and syringe. That short acting should be taken 30 to 60 minutes before meals. And then if you have pre-mixed, which is a combination of a longer acting and a shorter acting, that should be taken 10 to 30 minutes before breakfast and before dinner, because it does have that long acting combined with the short acting. Then we talked about basal. Okay, so basal, remember, that's kind of the one that is releasing insulin all throughout the day. That happens naturally for the person who doesn't have diabetes. Their pancreas just releases a little bit of insulin all throughout the day. So that intermediate acting, that typically covers half a day. So a person would be taking that intermediate acting basically in the morning and in the evening. The long acting would cover all day. So they would be taking it either in the morning or in the evening. Again, this is an individualized approach to that care. So it's whatever actually gives them the best results. And then there's also ultra long acting, which can cover 36 or more hours. So we do have options for basal insulin. So what are the characteristics of insulin? And we're going to talk a little bit about these. But what's important to understand is that each of these different types of insulins we talked about have an onset. How quickly do they work? So, for example, we talked about ultra rapid acting insulin, that inhaled insulin, that's going to work in 12 minutes. We talked about some of the rapid acting and the short acting. Those are going to work anywhere from 25 to 45 minutes, the onset. So that's how quickly those insulins will work to take care of that mealtime carbohydrate. Then there's also a peak. So basically, what is the time it takes for that insulin to kind of get to a point where it's doing all of its action before it starts coming out of the system? And then there's also the duration. So how long does it take to actually get that insulin completely out of the system to be sure that you aren't overdoing? So again, when you think about, like, let's say someone ate something and they take one of the types of insulins, they need to know when that insulin will stop working before they potentially have insulin for an additional snack or an additional meal. So that duration is actually really important. So let's look at the physiologic insulin. Here's what we need to remember. This is basically what's happening with a healthy pancreas. The pancreas is releasing just a little bit of insulin all throughout the day, but when a meal is eaten, then the insulin is released. So what you see here is, for example, at breakfast, insulin is immediately released, and then that slowly decreases because then people are not eating, and there's no reason for that insulin to be released. So you see how it gets really low again until it's time for lunchtime. And then as soon as lunch is eaten, that insulin spikes. And so what we're trying to do with the insulin that a person is prescribed and taken throughout the day is we're trying to mimic this physiologic insulin intake. So that's why there's the basal insulin, the insulin that's released all day long. And then there's that bolus insulin, the insulin that is taken to cover each of those meals, breakfast, lunch, and dinner. So what are we trying to do? We're trying to get to target. So that's why this insulin is so important. I mentioned earlier today that that diabetes is progressive. So people with type 2 diabetes, if they find that lifestyle changes and some oral medications have not gotten them to these goals, that's why they may start taking insulin. They may take basal insulin, they may take mealtime insulin. It really depends on that individual care and what they are most comfortable with, which delivery method, etc. But what's really important to note here is that the American Diabetes Association has pretty strong glycemic goals for adults with diabetes. And of course, this is for non-pregnant adults because it's a little bit more stringent for pregnant adults because they're really trying to protect the baby. So for non-pregnant adults, an A1C of less than 7%, this A1C really is kind of a big picture of how has that blood sugar looked over the last 3 months. And so we want to see that in the less than 7% range. That fasting blood glucose, so that's the blood glucose that you would take if you woke up in the morning and you haven't eaten for about 8 hours, that's fasting blood glucose. We want to see that in the 80 to 130 range. Then postprandial blood glucose. This is, you can just think of this as your post-meal blood glucose. So 2 hours after meals, we want to see that blood glucose being less than 180. We want to make sure that as much of that sugar that was in the bloodstream is taken from the bloodstream. And remember, that insulin is unlocking the cells and the sugar is getting into the cells instead of staying into that bloodstream. So we want to see that being less than 180. Now, here's what's really important to know. For people who are taking insulin, the most common side effect is a low blood sugar. Often that's because maybe too much insulin has been taken for the amount of food that was eaten or the type of food that was eaten. So the first thing to realize is that there are specific symptoms of hypoglycemia. Those symptoms might be a fast heartbeat, they might be shaky, sweaty, nervous, confused, dizzy, hungry. But here's something I want to make sure that you're aware of. These same symptoms for a low blood sugar are actually similar symptoms for a high blood sugar. So the first thing the person should always do is to check their blood sugar. So if it's less than 70, then the person knows they are having a low blood sugar. And then what they need to do is follow this rule of 15. So the rule of 15 is really important because what this does is it brings the blood sugar up to a normal level, 80 to 130, but it makes it where it doesn't pop up to such a high level that there's too much sugar in the bloodstream. So this rule of 15 is that a person would take 15 grams of fast-acting carbohydrates. So I love that this picture of orange juice is here because that's fast-acting carbohydrates. That's going to get right into your bloodstream without being delayed by any fat or any protein. You want straight carbohydrates when your blood sugar is low. You don't want to eat something like a Snickers bar, for example, because the high fat content will slow down that absorption of carbohydrates, and it may make your blood sugar continue to go down. So you want something that is very fast acting. Orange juice, jelly beans, but making sure that the total amount that you have is only 15 grams of carbohydrate so it doesn't spike your blood sugar back up. Then 15 minutes after you've had those 15 grams of carbohydrates, you're checking your blood sugar again. After those 15 minutes, if you get it above 70, then you just need to eat food now with protein and fat to keep it up. But if it's still below 70, you need to go through this process again for this rule of 15. You continue to do it until that blood sugar gets up above 70. But once it is, you should have something like half a cheese sandwich, half a peanut butter sandwich, something like that, that it's a combination of protein, carbohydrates, and healthy fats. So that's that rule of 15 for any time you have a low blood sugar. So what's really important for people with diabetes and people that are living with diabetes? There's a variety of things. One, and you're all doing this because you're here today, you should be getting education and support. You should be getting support from people like dietitians, nurses, pharmacists, your providers, and they should be working together to really help you with an individualized plan to improve your blood sugar, to decrease risk of complications, and overall to improve your quality of life. And so some of the things that you would be talking with them about is, what are the appropriate ways that I can eat well? What are the things I need to know for healthy eating? And I love this visual of the plate method, because this will really help when you're thinking about, how do I make sure that I am not having a meal that is really high in carbohydrate that's going to end up spiking my blood sugar? And a lot of it can be done through visuals. So if you think about the plate method, the majority of your plate should be vegetables. And then the other half of your plate should be protein, lean protein, chicken without skin, fish, lean meat, things like that. And then healthy grains, and thinking about your portion sizes of those so that you're revolving your meals more around fruits and vegetables and less around things like pasta and rice and potatoes. You can still have those, but you want to be thinking about having them as a small side rather than the main portion of your meal. So be thinking about those kind of things when you think about eating well. And remember that based on the foods you eat, if you take insulin, you would be taking insulin to cover those higher carbohydrate foods. Next is managing your blood sugar. Obviously this one, oh, Sandra, you're muted, but I see you there.
Before you go on, we have a question. The carbs we give as meals after insulin should be complex carbs?
Okay, sorry, repeat that one more time.
The carbs that we give as meals after insulin, should they be complex carbs?
Either one. So you're counting total carbohydrates, whether it's simple or complex carbohydrates, no matter what, you would be covering all of those. So if you're doing label reading or portion sizes to determine the number of carbohydrates that you're covering with that insulin, you're thinking total carbohydrates that you're covering with that mealtime insulin. So it is both. Now, what you want to think about is always making sure that those carbohydrates that you do eat have the highest nutritional value. So it's thinking about having those, what those carbohydrates are, thinking about things like brown rice instead of white rice, oatmeal and things like that for breakfast instead of regular cereal or sugary cereals. Making those kind of changes will increase the fiber intake and decrease any of the added sugar intake and things like that. So be thinking about that. And then the last thing there for, thinking about life with diabetes is preventing diabetes complications. So if you're doing everything you can to manage that blood sugar and to get that sugar out of the bloodstream and into the cells, you will be doing a great job to prevent complications. Complications are typically caused by prolonged elevated blood sugars. Because what that means is that that sugar has stayed in your bloodstream and stayed in your bloodstream for such a long time that that's when damage occurs. Blood vessels will break in places like behind the eye, in the ears, in the heart, in the kidneys. These are all places where there's potential for complications, but only when there's this prolonged high blood sugar. So that's why doing things like, for example, taking insulin with meals will prevent that prolonged high blood sugar. So those are just some things to think about when we're thinking about overall life with diabetes. So the last thing I had here was just some references, and I'll leave these here, but I'll pause here just to see if we have any questions or any other topics that you might want me to cover, Sandra?
Sorry, for some reason, my microphone doesn't work unless I'm on camera now.
Oh, no
so
worries.
yeah, so we are fine right now. We don't have any questions, but it's good to open for questions now. So please, if you have any questions, just let us know. I do have questions, I always do. So Joan, tell us a little bit about other diabetes medications that are injectables. You know, a lot of people are like, oh yeah, I am on this new kind of insulin, but they're not really insulin, they're other kind. Do you know a little about that?
Yes, so the other kinds of injectable medication, which is not insulin, is actually used for a variety of reasons, but the main reason it's used is actually to slow down gastric emptying. And so it slows down the absorption of food, it slows that gastric emptying. And what that does is it actually helps people to feel full sooner. And it actually slows down the absorption. So it will prevent that spike in blood sugar. And we want that because we want blood sugar to kind of stay more stable rather than the spike and the decrease. And these types of medications that are injectable but not insulin will also have that role. Sandra, I see someone asked about fruit.
Yes, so are fruits not good because of the added sugar?
Okay, so one thing I want you to remember about fruit is that fruit is natural sugar. And what I want you to remember about that is typically a lot of fruits also have a good source of fiber. When you think about fruit, the main thing you want to think about is portion sizes. So for something like an apple should fit in your hand like a tennis ball. If it fits in your hand like a softball, it's too big. If it fits in your hand like a tennis ball, it's fine. And so if you're thinking about fruit in that way, that it's good for us in the appropriate portions, that's what's going to be important. So you can have fruit. I would suggest, one serving either at each meal or maybe having it as your snack between meals, but really thinking about the portion sizes.
Next question, how often should one check their blood sugar daily?
Okay, great question. So often people are prescribed a certain number of times to check their blood sugar each day. So maybe they're prescribed to check it only once a day. But what's really important is that we aren't checking at the same time every day. So let's say that they are only checking once a day. They could check fasting when they wake up in the morning. And then the next day, 2 hours after breakfast, the next day, 2 hours after lunch, and the fourth day, 2 hours after dinner. And then on the fifth day, they go back to checking it when they first woke up. Because after about 3 weeks, then we can see, okay, are we having any issues with their blood sugar when they first wake up? Are we having any issues with their blood sugar 2 hours after breakfast or 2 hours after lunch or 2 hours after dinner? And we can still get to see any trends that there may be in their blood sugar, even if they're only checking once a day, because after 3 weeks, we're going to have, 6 or 7 from each of those different time slots. So it's more important to know how many times have you been prescribed to check your blood sugar? And then once you know that, making sure you're using that information to think about when you want to check your blood sugar and really making that diverse so we can really find places where if there are places where your blood sugar is still high 2 hours after a meal, we can then think about what are the foods you like to eat during that meal and can we make some alterations?
Perfect, thank you for that. Now,
Sure.
here is another question, like people kind of start on pills, then they move to injectables that can be different times a week or weekly. Then they will move on to insulin. And, you presented that there are different types of insulin. They can be injected, they can be on a pump or inhaled. What would be pros and cons of each? Like, for example, if I'm taking my mom to the doctor and my mom has diabetes and she needs to be put on insulin, how do I know which one will be the best one for her?
Such a good question. All right, so really there are so many things to think about. One is if the person, for example, has dexterity issues, any issues with vision, those two things would definitely be reasons why they wouldn't be good candidates for something like a vial and syringe. Because it's going to be really hard for someone with dexterity or vision issues to be trying to draw up their insulin.
Mhm.
So that would be something to think about, specifically barriers for a vial and syringe. When it comes to something like a pen or a pump, a few things I would mention about that. One is, the person, something like a pen, for example, it can be helpful because they can hear the click each time they add a unit. And so that can be helpful for someone, again, who does have any vision issues. Even for dexterity, it can help them. And so that may be a good option for those people who can't be on a vial and syringe. That could be a good option for them, for having the pen. For someone with a pump, typically if we have people that are more tech savvy, or people who just want to have something where they're only changing that infusion site every 3 days. Maybe this is someone who really doesn't want to do all these injections in front of friends or family, that kind of thing. That could be a really good candidate for a pump because they really like to see those numbers. They like to hold it as far as the technology. So that could be a good option for them. And then inhaled insulin, to me, that's an option for people who are having issues with those spikes in their blood sugars and any hypoglycemia, because inhaled insulin is so fast in and fast out that typically it decreases those risks. But then also for people who have any fear of needles, if they have needle phobia, that kind of thing, so that they can still be taking their blood sugar still be taking their insulin with each meal, but they wouldn't have to be doing it as an injection. So these are just sort of a few of those reasons why one might be a better choice over another. But in the end, it is totally, an individualized approach to the care based on really what is going to be most comfortable for that person and what's going to help them take their insulin as it's prescribed.
Does the patient have a saying in what should be prescribed? For example, most of the time we go to the doctor and we just wait for the prescription, but oftentimes, talking about social determinants of health, like where the pharmacy is, the cost of the medication, fear of needles, there are some things that sometimes as providers we don't take into consideration. So as patients, do we have any input on what can be prescribed for us?
Absolutely. And what I really like to tell people with diabetes is that they can be their biggest advocate. And so if they know the information we've talked about today and their provider says they need to start on insulin, what I hope is that they are then saying to their provider, I want to talk about my options. I know that I don't have to be on a vial and syringe. I can be on a pen or a pump or inhaled insulin, which are all great alternatives. And they should be saying, this is the one that I think is best for me, and this is the one I want to try. And really being, again, their biggest advocate for the care that they want to receive. that's going to be so important, because a lot of times people will just wait and see what goes to the pharmacy.
Mhm.
But then the issue is that 50% of medications are not taken as they're prescribed.
Mhm.
And I think it's because of this, because there's not this shared decision making, which is what should be happening between the patient and their provider, is they should be making this decision together as to which mode of delivery is best for them for insulin.
Mhm. Also, I think lifestyle has something to do with that, right?
Mhm. Absolutely, because somebody might decide, for example, with the pump, that they don't want to have to be taking that pump on and off if they are going swimming, or if they're an active college athlete, or, there's all these reasons, why things might be best for one person and not for another. Lifestyle is definitely one of them.
Mhm. There are a lot of people who don't like insulin at all, and once they get prescribed with insulin, they're like, "I'll forget about it."
Mhm.
And you said it during your presentation, if your sugars are out of control, that's when the consequences start, and you start having vision problems, gastric problems,
Mhm.
feet infections, things like that. But is there any research that shows how long it takes? For example, if I decide today, oh, I'm not going to do anything more for my diabetes, is there any research that says, okay, in 6 months you're going to be blind, or in 1 year your kidneys are going to fail? Any?
Right. So what it all depends on is that prolonged high blood sugar. And so there isn't necessarily something that pairs it with a time frame. But what we do know is that when that blood sugar is over 180, and it stays over 180 for prolonged periods of time, that it is that blood sugar range, 180 and above, that complications can occur. So some people may have blood sugars in the 400s, 500s, 800s.
Mhm.
They're going to see complications much faster than someone who has prolonged hyperglycemia in the 200s. They're still going to see those complications occur. It just might take a little bit longer. So it really depends on the level of high blood sugar and how long that high blood sugar has been an issue.
Mhm. Now, can you combine different types of insulin? For example, you can be on the injectable and at the same time on the inhaled, or, things like that.
Yeah, and so, for example, somebody could be taking basal insulin, which is that insulin that they need to be released all day long, just like a healthy pancreas would do. So they may inject that once a day, but then they would need that inhaled insulin, for example, to cover their meal times. So they may take an inhaled insulin with breakfast, lunch, and dinner, and also a very small dose of inhaled insulin if they have any snacks during the day. So technically they could be on this combination delivery mode where they're taking that basal once a day, so which means they'd only have to take one injection a day, and then they would have inhaled at each meal.
Mhm.
This is the same, they could be doing kind of these different modes of delivery just based on their individualized preferences.
Mhm. Now, there are a lot of people who don't want to take their insulin due to shame, for example, or at some point you mentioned that, like, they
Mhm.
don't want to do it in front of their friends, or having to excuse themselves to go to the bathroom to do it. How do you deal with that feeling of shame? Because some people also isolate themselves, right? They don't want to go out, they don't want to be around people. And some others, just as you said, 50% of people out there don't take their medications correctly. So others might just go out and don't take it and then be sick for the whole weekend.
Right.
So how do you deal with those feelings? Like, what can we tell people so that they feel better about this situation and started using insulin as directed?
Yeah, it's really hard because this is a big change typically in someone's lifestyle. And so we really have to approach it as, how can we help you make this part of your new normal? How do we help you change your behavior? What are the things that are causing you to feel this stress and anxiety about this? And are there people around you that you trust, that you can talk to about this so that you can feel more comfortable? I mean, that's going to be really important, because what we know is that this insulin is going to really help them improve their quality of life. But if they're feeling this stress, we have to work with them to overcome that stress. So what I always suggest is start with a few people that are in your circle who you really trust and love, and you know are not going to judge you because of this treatment plan. And really have conversations about what is it that they can do to help you. And maybe it's talking to their friends about, when I do this, I don't really want it to be a big deal. I want to be able to just take my insulin, and I want us to keep going with our conversation. And maybe it's setting up those boundaries so that then there is comfort for both the person with diabetes and the people that are with them. Because I really do think that if you just have a few conversations early on and right away, it can really help to not make it in any way an uncomfortable situation for both the person and their family or their friends. So I think those early conversations really do help. And I think then over time, everybody feels a little bit more comfortable with it. And it really does help to decrease the discomfort kind of as quickly as possible. So I do believe in just early conversations, really setting up the boundaries of the kinds of things you want to discuss and not discuss. I think all of those things can really help.
Yes, thank you for sharing that. I think that that's very important for a lot of people to acknowledge. And, I was looking through our list of participants, and there is a lot of women there. And I feel that, it's like when you get pregnant, if you've ever been pregnant, starting to tell people about your pregnancy, it's weird in the beginning. And then everybody is like, oh, you're pregnant, like it doesn't matter. But in the beginning, it's a little awkward. And I think that is the same thing with a lot of chronic diseases. So the pregnancy is like a happy event. Chronic diseases are not so happy, but once you start telling one person, then another person might be like, oh, I have diabetes too. And your circle starts to grow, and you normalize the situation a little bit.
Yes.
So I love what you said about just start telling your inner circle. And it definitely expands little by little. And you might see that, especially now where we are now, so many people have diabetes out there, right? 1 in every 3 have pre-diabetes.
Yes.
1 in every 5 have diabetes. So if you look around you and you have a table of 12 people sitting with you, at least 2 people that are going to have diabetes. So if no more. So yeah, I think that's a good thing. A lot of people are now familiar with diabetes, and those who don't have diabetes like to help those who have diabetes. So, okay.
Absolutely.
Joan, we don't have any more questions. I don't know if you have anything else that you would like to add.
No, just if anyone has any questions, about insulin, inhaled insulin, if they send them to you and you want to send them on to me, I'm open anytime for any questions. I'm happy to help.
Perfect. Thank you so much for this nice review and discussion. And I hope all of our participants have learned a little bit more about insulin today. And really what we want to do is to empower you, to get you the knowledge so that you take care of your diabetes, that you feel that you can go to your provider, talk about the different options that you have, and do the best for yourself or for your loved ones who have diabetes if you're not the person with diabetes. So thank you, Joan, once again. And we close the diabetes month with this great presentation. I will see you again on Thursday. I believe it's December 1st. We're going to be talking about holidays and mood. A lot of people get kind of blue when the holidays are here. You know, you start remembering family members, you start remembering a lot of things. So even though everybody says happy holidays, might not be so happy for a lot of us. So let's talk about it on Thursday at 12. I'll see you then. Thank you, John. Thank you to everyone who joined us today. Bye-bye.
Bye.